So at EMC, we believe that we are rightly poised to enable the healthcare ecosystem in India to take that next leap, to move towards a fully digital healthcare delivery model, where there is an end-to-end solutioning from the primary health all the way to tertiary and home healthcare. The idea is that we want to look at technology as a way to sort of solve the problems of access and equity of healthcare, whether you are staying in an urban center like a Delhi or a Bangalore, or whether you are staying in a rural village in Karnataka, or for that matter Uttar Pradesh, you should be able to get the same kind of services that somebody sitting in Delhi is able to get. I'm going to focus more on the public side. We have booth outside and a colleague sitting there. If you're interested in any aspect of the solution, looking at partnerships with us, trying to come and say, here is a problem, could you solve that? We look forward to any and every opportunity to serve each one of you. Typically, a PHC caters to about 30,000 people. So if you take the entire nation scale ecosystem, we have today about 25,000 PHCs, and 5 to 6 sub-centers per PHC makes it 1.5 lakh sub-centers. Now, each of them ideally should have a male and female workforce, so we are looking at about 3 lakh people who are doing the service delivery on the ground. And whom are they going to reach? They are going to reach 750 million people in the rural setting. So at nation scale, this project, we believe at a very conservative estimate, would come back about 50 terabytes per year. And the way we are looking at building this system is it's a birth to death record. Once you are in the system, anytime you are taking a service from government or a private service provider eventually, or you are taking insurance way to get some service, that record will come back into your electronic health record. So the data never goes away. It might go into a backup or a dormancy phase, but anytime anybody who is given authority by the individual, so all these records are Aadhaar authenticated, so the individual has the right to go and say, I want to go to hospital A and Dr. A, and I want to allow the doctor to actually look at my history, and we want to enable that to happen. Simply by pressing their finger, they can give that authority for the doctor to take a look, right? So that's where we are looking at. Once we have the data, then the bigger challenge comes. Getting the data, we have been on the ground to actually cross the barrier. Today, everything is done on paper, right? And I'll talk about the challenges there. But what we have done is we have shown that we can go from paper to digital in about 6 to 8 months' time. We have done that in this particular rural village, which is primarily tribal. The health workers are also tribal women and men who actually do the service. We could train them to use this modern technology and show value to what they are doing, and be able to give them time back for their own family and children to spare, right? How can big data and the technology come into play? So let's take a look at how pregnancy risk is modeled today. And this is a chart that looks at, on the right is actually the condition that we are trying to monitor, which is pregnancy, what complications can come, and it could lead to serious issues during pregnancy, post-pregnancy, and even maternal death, right? In the middle are the intermediate factors. So in the top are actually the factors which I listed, which is the kind of demographic factor, the age, the height, and pieces of that. You also, your past history. If you had a high-risk pregnancy in the past, you likely will have one in the future. So those are easy parts. But look at the last quadrant, which are sort of distant factors that will come into play. And on the bottom is more interesting. There are unknown factors. There are known knowns, there are unknowns. And you're expecting somebody who is an 8th pass, who is a tribal woman, to actually figure out all this and come and tag somebody as high risk and ensure that our numbers are looking good, right? So what we did, we said, let's try to enable this lady to do her job better. And that is pretty much what we want to do with technology, not to replace the person, but make the person more efficient to provide the service. We looked at the entire model that I showed earlier. We computed these scores and looked at what scores are predominantly happening, right? And what we have come up with is something called birth preparedness score. It is not a maternal mortality score. It is essentially saying that whenever a woman enters into this system, how ready is the person for doing a delivery, right? And when the first day of registering into the system, you have a score. And as you get services, the score will go up and down. And as you get feedback from the ground saying, okay, her weight is dropping, her BP is going up, the score will keep going up and down. But what it is doing is that on this tablet, this lady now knows the risk score, and that score, as and when she is syncing back to the central server, the doctor at the PHC can look at it. The next time the lady is visiting, the district medical officer can actually see these are all the ladies being tracked today, and these are the risk scores, and here is a bar that I have set. And the moment the bar goes below or above, I will go and make sure that simply by an SMS that, okay, move this lady from regular normal pregnancy to high-risk pregnancy. How will you do that? This is how you do that, right? So at the bottom, this is actually data we took from the ground for some of the past pregnancies that have happened. On the bottom, you can see the actual outcomes of the pregnancy, whether the mother was alive or dead. And what we have done is on the top, we have taken two factors, and these two factors are not there. The age is there. Today, they look at the age of the mother, right, in trying to assess whether it's a pregnancy or not. What we have taken is education level, because education is a socio-economic, is an indirect factor that sort of says your socio-economic level in the society and how that impacts high-risk pregnancy. And we have seen that there is a lot of correlation with that. And with this kind of data, you can go and say the moment somebody comes from a certain region with a certain socio-economic background, their score is going to be this, and there is a high likelihood that they might eventually become a high-risk pregnancy. So that's what our target is, so trying to actually bring technology into day-to-day service delivery and make it more and more efficient. As I said, Rohini is already burdened by keeping all those books and records. She doesn't want to really actually have to compute in her mind this complex mechanism of figuring out who is a high-risk pregnant lady, right? But this is just the tip of the iceberg, right? When you have data, you really want to do much more than this. Right? What can we do for India? So this is something that we could do for India. This is New York, and if you go to this site, based on disease analysis and disease occurrences that have happened, you can tie it back to say which bacteria are found in which places. This is New York, the metro system, and you can actually go and say what bacilli has been found and what is more predominant in which area. So can we do this for the entire India? We can. Once we have all that data coming in, we have all the disease profiles coming in, we can always go back and say, anytime you go to any place, and look at the way this can be used. There are multiple uses for this. You have a Kumbh Mela, you can always already plan what are the outbreaks that will happen at Kumbh Mela, because we know these are the viruses or these are the bacteria that are around in these banks on the river Ganga. Or you have a traveler coming in, he or she can go to the website and say, these are the medications I should actually take, because these are the kinds of things there. I don't want to take TB or a measles vaccination because the place I am going to doesn't have a prevalence of those, right? The next big thing is actually to look at a human disease network. This is a study from academia which is trying to say, if you have a certain type of cancer, what other kinds of cancers are they most correlated to? What parts of your body gets infected? What parts of your body should you start focusing on, right? And what I'm trying to show is that there is a possibility of bringing all this data and going towards the notion of personalized medicine. Can we now go, even at the scale of India, for each and every individual in a rural setting, can we go back and map the individual's DNA? Because we know when the child is born at the PHC, it's very simple to get a DNA. And once you have that DNA, you can actually map it back to the diseases, the models, and we need to create those because the West does not have the Indian models and the Indian DNA today. So those will take time, but there is always a first step. And we believe technology and we as a group here, we are asking the right questions, right? And we will find the way, right? But maybe this is what we should be looking for, right? And this is somebody who is actually out there saying that a person who is going to live till 150 is already born, probably he is 50 years old today. And he is saying that in 2 decades, there will be somebody who lives to 1,000. Now, if you and I are going to live to 1,000, I have not planned for 70. So if I were to ask what would you do if you were to live to 1,000, I would have to do several more PhDs to begin with, and that's a daunting task, right? You need to reinvent yourself as an individual, right? Not just as communities, as enterprises, but if you could live that long, and I know which group would want people to live 1,000 years. Those are the space explorers. They would really want their astronomers to live 1,000 years so that you would go to Mars and you come back, right? But there is this possibility. There are already pockets of communities who have high life expectancy of above 100. And this is not impossible. This person here is a very accomplished physician. He is a cancer specialist, and he has his own research foundation which runs competitions which gives a large enough prize for somebody who negates this idea. And so far in the last 3 years, nobody has come with strong enough reasons that say this is not possible. Every idea that has been put forward to him has been sort of negated, saying these ideas do not span. We can actually live long. Eternal is a target. With that, I'll thank you again for taking time and listening to me. Thanks.